going to talk about thrombophilias, and which is we're going to specifically focus on hypercoagulable states and inheritable hypercoagulable conditions. Okay, so our first case is going to be a 33-year-old man, previously healthy, presented with sudden onset dyspnea and sharp right-sided chest pain, with right leg edema and calf discomfort a week earlier, denied any trauma, surgery, or immobility. His mother had a history of postpartum DVT. On physical exam, he's tachycardic at 114, normotensive, and hypoxemic. And contrast-enhanced CT demonstrates segmental pulmonary emboli and right lower extremity DVT on ultrasound. And just as a pause for a moment, there's so much that we do looking at that clinical scenario. We assess the risk based on parameters that have now become well documented, and there are tools that we can use to help us decide when to get that CT, the risk of pulmonary embolism, the risk of DVT, and all of this information we process is now part of standardized tools that actually can really help with all of that. So that's the first part of this. Here's another case scenario. Again, we're going to synthesize all of this clinical history. A 78-year-old with hypertension and obesity and acute left leg edema, 2 days after an open reduction ORIF of a right hip fracture, physical exam, severe edema and tenderness of the left lower leg and thigh, and she had a venous ultrasound. Again, someone made that decision based on that clinical presentation to get the ultrasound, and she had left common femoral, distal femoral, and popliteal DVT. So the definition of a thrombophilia is a disorder that has an increased tendency to thrombose. That's what that means. And so we have this constant balance going on. All of these factors are constantly balancing between bleeding and clotting. All of the factors that we're going to talk about now get turned on, turned off, all at the same time. Everything is happening in this delicate balance so that we don't overclot and we don't overbleed. So we have endothelium, we have injury, we have exposure, we have platelets, then we have activation of platelets, we have cascades, intrinsic and extrinsic pathways for plasma factors, for procoagulation, as well as anticoagulation. So again, another mock-up of this, blood vessel injury leading to aggregation and constriction, and then a cascade with a stable primary plug. Here we go again, adhesion of those platelets. The platelets become activated in the face of endothelial exposed tissue factors, secretion, aggregation, and contraction to get a primary hemostasis. And then there's a secondary plug, secondary hemostasis, with the activation of all of these protein, serine proteases and the activated phospholipids on the surface of the platelets and the endothelium. And here we look at the intrinsic and extrinsic pathways. And this is, again, all happening in concert, perfectly blended, so that, again, we don't overclot, we don't overbleed. And so you can see the intrinsic pathways, those factors that are associated with that. Each A means activated. And then the extrinsic pathway, where we're going to have tissue factors exposed from the subendothelium, and factor 7A, all combining with prothrombin, which is factor 2, 10A and 5A going to 2A, and thrombin, which leads eventually from fibrinogen to fibrin to cross-link fibrin polymers, so you get an organized secondary plug. And here we have a look at that. So again, the initiation, and then again, that's just one small start that has to become amplified, propagated, and then it terminates. So they're going to be, as we see this this pathway, we're going to see where the regulation factors fit in just a moment. So the regulation factors, antithrombin 3, it's going to regulate the presence of thrombin and the activity of thrombin, as well as all of the remaining serine proteases. And it can be inhibited. The inhibitory effect is enhanced by heparin. And then protein C and S, which are going to, protein C is going to be activated together with a cofactor. Protein S is going to regulate factor 5 and 8A, and then there's a fibrinolytic system. So here we take a quick look. Again, same picture pretty much, except we have some additions to it. We have exposed endothelium with factor 8A and tissue factor. Our intrinsic factors, then the extrinsic pathway is also running. However, now we see that as we're forming these fibrin cross-linked secondary polymers, we're also seeing the activation of activated protein C and protein S to destroy factor 5A and 8A, again, to downregulate this system because we don't want to overclot, as well as antithrombin. So we need antithrombin and we need activated protein C and protein S. And that'll be important in a moment. Another slight way of distinguishing this, so we sort of get a little handle on this, is arterial thrombi, again, high shear rates, venous thrombi, low shear rates. Arterial thrombi, primarily platelets and fibrin strands. Again, the factors that we're going to talk about, that we've talked about previous lectures, in terms of treatment, you can understand why the antiplatelets would be great in the arterial system, but not quite as strong in the venous system, because we're not really looking at antiplatelets there. We need other pathways to deal more with the fibrin strands, and hence the 10A inhibitors and so on, thrombin inhibitors. The arterial thrombi is atherosclerosis. I mean, we're all familiar with that, and the venous thrombi in areas of stasis, and we'll talk about that in a moment. Arterial thromboembolism, stroke, MI, and venous thromboembolism, pulmonary embolism, again, left heart and right heart circulations. So when we talk about Virchow thrombosis mode, we look at vessel injury, we've talked about that, and then coagulability, and then blood flow. We combine those for thrombosis. When we want to talk about injury, we can talk about atherosclerosis. We just talked about that in the arterial system. Immune mediated, we're going to look at HIT for a moment, as well as antiphospholipid antibody syndrome. Of course, trauma, artificial surfaces, inflammation, infection. We're going to decrease mobility. Right, blood flow, decreased mobility, which can be a long-term hospitalization, an injury, trauma, and then unique situations like economy class syndrome and the rest. And then we're going to look specifically at these hereditary risk factors: antithrombin 3 deficiency, protein C deficiency, and protein S deficiency. Again, protein S, C, and antithrombin are necessary to downregulate the coagulation cascade, so deficiencies will cause them to clot. Whereas factor 5 Leiden and prothrombin are gain of function, not loss of function. They, by the gain of an abnormality, a resistance, so to speak, they are going to lead to clot as well. Most of these that we just talked about are associated with venous thrombi, except the antiphospholipid syndrome specifically. It can be, and it's not always. Some people with antiphospholipid syndrome can have or antiphospholipids can, in testing, can really just have malaise, and they don't have to be horribly aggressive, but it can be a very horribly aggressive disease with venous and arterial infarcts, as well as loss of pregnancy, multiple loss of pregnancy. So it can be quite a devastating disease. Here we're looking at the protein C and S system. So they're both vitamin K dependent proteins produced in the liver. So again, liver disease, vitamin K deficiency, warfarin treatment will downregulate those factors. Protein C is activated again by thrombomodulin. So you're making thrombin, but you have to downregulate it at some point. So actually what you're making and creating, this thrombin thrombomodulin, is eventually going to downregulate downstream from where you need it to clot so that you don't continue to clot. Protein S is a cofactor, and activated C and S degrades factor 5A and 8A, as we talked about. So here's that picture or mock-up of that downregulation where we have thrombin being made, and then thrombin thrombomodulin are going to downgrade or destroy the activated protein C so that we don't continue to clot. And this then is actually, we're missing a slide here, so there's a little extra here. And this is where we have activated protein C and S as its cofactor, degrading factor 8A, and it would degrade factor 5A, except that the 5A is an altered 5A. In this case, it's a factor 5 Leiden, which we'll talk about in a minute. So the protein C system, 3 abnormalities: protein C, protein S, and a mutation of factor 5 cleavage site. So where you want to destroy the factor 5, you can't, because it's a single point mutation. Protein C deficiency can be autosomal dominant. Most patients, it's heterozygous, so it's not as severe. When we talk about this pulpirofulminans, understand that anywhere where you're massively altering the coagulation cascade, you can have these infarcts in the skin, meningococcemia, DIC, much more common, obviously, than protein C autosomal deficiency. But pulpirofulminans is more of a clinical descriptor that can occur with that. Activity levels will be seen at the 50% normal mark, and an increased risk, of course, of venous thrombosis, just as we've said. Acquired protein C, just as we talked about, warfarin is going to chew up protein C, ongoing thrombosis. So again, if you're treating somebody, or if you have an active thrombosis, that would not be a great time to be looking for protein C deficiency, vitamin K deficiency, liver disease. Protein S, cofactor. Most of it is bound, so it is the free protein S that gives us, and that is inactive. So it is the free protein S when we're looking for protein S deficiency. Again, these are assays for protein C and protein S when we're looking to see how much actually we have. So protein S can be autosomal dominant, or it can be an acquired deficiency. Again, liver disease, and then some other diseases affecting the gut, I guess, IBD, OCPs, and renal disease. The clinical picture of these hereditary thrombophilias, this is not the best slide, because basically when you're thinking hereditary thrombophilia, it's someone who has a unprovoked DVT early in life, right? But the trauma surgery thing is a little misleading, because you're looking for recurrent disease, you're looking for unusual disease, severe disease, loss of pregnancies. Having a DVT associated with trauma and surgery can be almost sort of expected sometimes. So like with hip surgery and knee surgery. So I think the first part, which is 20s to 40s and an unusual loss of pregnancies, those are reasons to think about these hereditary thrombophilias. And then again, we just talked about warfarin associated skin necrosis, chewing up those factors. Computer's just jammed from it. There we go. Now we're going to talk about this factor 5 Leiden. So at some point in time, they did genome-wide testing when they saw all these clots, and they looked at all these people in Leiden, England, and they saw, wow, you have this gene mutation and you're all clotting. That's how they figured it out. That's why they gave it the name factor 5 Leiden. There's also factor 5 Cornwall, but it's just not as, for one reason, factor 5 Leiden stuck. And it's a activated protein C with a point mutation at 506, and it's a replacement of arginine for glutamine, and it becomes factor 5 Leiden APC resistance, so activated protein C resistance. So again, when you're, as an aside, we're going to get to it later, but you're going to test, you're going to do your standard PTT, APTT, but then you're going to add activated protein C to be able to distinguish if it's activated protein C resistant. Increased risk of venous thrombosis, again, of course. And here's just a mock-up of the point mutation. So again, activated protein C resistant assay. Determine the APTT in plasma before and after activated protein C is added. We also will do a factor V Leiden genetic assay. However, if you have been doing these, you see that the lab will run the APTT, and then if it comes back that it's normal and there's no reason to suspect protein C, they won't run the genetic assay. If it doesn't, then they'll confirm with the genetic assay. Antithrombin 3 deficiency, again, synthesized in the liver and endothelial cells, inhibits thrombin and those serine proteases that we talked about in that pathway. Remember the extrinsic and intrinsic coagulation pathways. It's resistant to unfractionated heparin, and you treat it with low molecular weight heparin. Okay, cause of decreased antithrombin is heparin therapy, nephrotic syndrome, DIC, and hereditary, both reduced production and an abnormal molecule. Clinically, again, thromboembolism, early in life, pregnancy loss, recurrent, unusual places, massive disease. And then protein thrombin gene mutation. Now, remember what we talked about is this is a gain of function, just like factor V Leiden. You're increasing. So the result here specifically is an increase in 30% higher prothrombin levels, and it has alternative effects as well. And it is this, I believe this is the second most common of the genetic mutations after V Leiden. When we talk about the damage, we talked about HIT. You sort of need to know that not everybody still does this, but type 1 and type 2. The type 1 happens very quickly. It's not immune mediated. It is benign and self-limited and doesn't require discontinuation, where and that's like within a couple days. If it is longer to onset, you have to be worried that it potentially is the type 2, which is an immune mediated IgG against the heparin factor PF4 complex, and you get very serious clotting. The incidence of HIT is 3 to 5% with unfractionated heparin, and within 5 to 14 days. Stopping the heparin is very important. Here's argatroban. But dabigatran is now an oral direct thrombin inhibitor. There's also the liverudin, I can't pronounce them, but there's a set of IV direct thrombin inhibitors. Dabigatran is the oral one. And then once the platelet count is above 100,000, warfarin here it's warfarin, but then they switch to oral. Okay, and here's some horrible pictures of these awful immune-mediated thrombosis. Okay, antiphospholipid syndrome, which we also talked about, can be quite dramatic. It doesn't have to be. A large percentage of the population on screening blood tests will have those antibodies. Doesn't mean they have the syndrome. Most common hypercoagulable disorder, characterized by, in worst case, multiple losses of pregnancies and thrombosis, and then combining that with antibodies against phospholipid and proteins bound to phospholipids. So you can have an idiopathic form, can also be associated, acquired with lupus, infection, drug reactions. 10% of healthy donors will have antiphospholipid antibodies. Again, that doesn't mean they have the disease. Many more, obviously, the percentage in patients with SLE, lupus anticoagulant antibodies, anticardiolipin antibodies, and anti-beta 2 glycoprotein antibodies. So again, you're going to be testing for those antibodies. One thing that is sort of counterintuitive is that the APTT lupus antibody, it's prolonged, right? And you'd think it would be increased clotting, but the unique thing is in vitro, it actually leads to prolongation. It's not very sensitive, and there are other testing, in vitro testing, that is more sensitive for it, but it's just a disconnect when you're looking at it and it says prolonged. Well, why is it prolonged? It's just the opposite in vitro and in vivo, how the test pans out. Vascular thromboses, arterial and venous again, and multiple unexplained pregnancy losses can be very devastating. Imagine at 34 weeks. Lupus anticoagulant, anticardiolipin antibodies, anti-beta 2 glycoprotein antibodies. One very important thing is that the diagnosis needs to be confirmed on 2 occasions, 12 weeks apart. Some people might test very early on. I mean, you'll see that as we go that there are reasons why that may be difficult, but let's say it's prolonged. Let's see, you see antibodies early on in your testing. If it's negative, that's great. But if it's positive, it doesn't carry enough weight, because acute thromboses can do that. It can raise the level of the antibodies. It can prolong the lupus anticoagulant APTT. And so you have to repeat it later on at 12 weeks. So when to suspect a hypercoagulability, this is what we were just talking about. A thrombosis, obviously a family history, right? Unusual site, massive disease, idiopathic, recurrent, unexplained spontaneous abortions. So who to test? This is really an interesting question. It was recently reported in the Journal of Vascular Surgery. There was a review, and for would testing change what you would do? And the answer is, if you've had a clot, testing doesn't do much. And it should be very restricted as to who you test, because it's not going to change what you do. Unprovoked DVT1, unprovoked DVT2, provoked DVT. Realistically, once you've had it, it's going to go on the clinical as to what it is. The specific testing is not going to change things very much. So you have to be reserved, because it's expensive and it won't really change what you end up doing. The other thing is, of course, many times, 60% of the times you're going to find something, 40% of the time you won't, but that doesn't mean the person doesn't have a hypercoagulable state. So this is just reiterating that you have to be careful about why you're testing and what you're trying to gain from that. You really have to have an endpoint in mind. This talks about a little bit about which tests you're doing. So again, factor V Leiden is that activated protein C, and then a PCR, prothrombin gene mutation is a PCR, protein S, C, and antithrombin are activity assays. Remember, protein S is going to be free. And then the lupus anticoagulant, protein PTT, lupus anticoagulant, the ELISA testing, and then that's a dilute Russell Viper venom test, which the exposure of the phospholipids, again, the science is a little beyond me, but that is a much more sensitive test for this process. Okay, so when do you test? At the time of the event, what are you going to gain from that? Probably nothing. You're going to initiate treatment and you're going to be testing. You're probably not going to gain anything from testing at the time of the VTE, and it is going to confound a lot of data. Your protein C, S, your antithrombin are all going to be depressed. Your lupus anticoagulant is going to be prolonged. Your antibodies are probably going to be elevated. So, most of these diseases, it's not going to be very helpful at all. Do you test while the patient is receiving anticoagulant therapy? Again, the anticoagulant warfarin is going to, protein C and S are going to be depleted. Heparin, your antithrombin, is going to be depleted, plus you're in the middle of a clot, which is also doing these things. Very confounding evidence. What are you going to do with it? And then next, if you have a strong provoking event, what's the utility of testing? Because that's a provoked event. With a strong provoking event, you're just going to treat based on that. You're not going to suspect anything else. And then consider testing when it's unprovoked later on, unprovoked, weak provoking, and you've got to know the goals. So, you have a young woman, she has a family history of factor V Leiden, she wants to go on birth control, she wants to get pregnant. Those are reasons to test somebody, because that's a very serious event. You don't want her with a history of factor V Leiden in her family to go on birth control and then end up with a clot, use something so silly. And you certainly don't want her to lose a pregnancy. So provoked, this is really what it's coming down to: provoked by a strong trigger, no role for testing. unprovoked, unusual, family history, um, uh, a weak trigger, which is almost like unprovoked, essentially, because that trigger has such a low likelihood of causing a clot. Those are reasons to consider, but you have to time it properly. There we go. The treatment is really anticoagulation. There really isn't a direct treatment. So now this is a tricky word play here. Initiation of oral anticoagulation for primary prophylaxis. So you have a person with a hypercoagulable state. Do they need to be on it for everything? That kind of prophylaxis. And the answer is no. However, if you're going to expose them to a high-risk situation, then you prophylax. This slide, there's another article in JVS, Venous and Lymphatic Medicine, that looked at European, US, mostly vascular surgeons actually, about 70%, as to what their, who they put on extended, the term is extended use. So here it's indefinite anticoagulation with 2 or more episodes, and one event or a strong provoking event is vigorous prophylaxis in a high-risk setting. Not everybody does that, and 70% of vascular surgeons in the US and Europe didn't do that. When you had one event, 70% were doing extended dosing. So in fact, I can give you some of the numbers because I just left it here. Recurrent iliofemoral DVT, 93%. Okay, just like we would think. Recurrent fem-pop DVT, 91%. How about first time unprovoked iliofemoral DVT? 80% did extended, and so on. And there are many other examples. So I think that extended in an unprovoked setting, you have to be understanding that it's not fixed in stone, that you don't use extended, and that a lot of people are doing that. And that needs to be studied really, I guess, because there's obviously an answer to that. It's just right now it's a little bit more all over the place. So, and this sort of says why, because the risk of recurrence, if the DVT occurred after a major risk factor, is 3%. But if it's a minor risk factor, it's 10%. So if you're looking, your 10-year and 5-year recurrence rate in someone with a minor risk factor, right? Unprovoked minor risk factor, it could be 30–40% chance that you're going to have a clot, another clot. And so that requires people to give that a second look. So some of this is consistent. Again, major transient risk factor, I would modify the 3 months to say until the factor is resolved. So if someone's had a fracture, they had no RIF, but they're still immobile at 3 months, you're probably not going to stop it at 3 months. But if they're back up on their feet, they're doing their things, the risk factor's resolved, I think at that point, yes, you're going to stop it. And if the person has cancer or more than one, it's going to be indefinite. And I think that you have to be careful about that, number one, indefinite, because it's not set in stone that that person, it stops. At least that's in practice, from that recent article, it's not. Now, I think it was pretty much only a very small number, like 20%, were actually doing extended dosing for distal DVT, the first one, unprovoked. But recurrent distal DVT, it was 50% were doing extended dosing. So here's some more. This is that first case. So this patient was young, family history of VTE. They looked at his clinical history. They got the ultrasound. They got a CT. They found DVT and PE, and then they tested him because of that family history and the fact that he had no provoking reason to have this. And they found lupus anticoagulant, and so he's on lifelong DVT, lifelong prophylaxis. The second patient She was treated for 6 months. Now, that's not the 3 months, that's sort of standard. She was treated for 6 months. Remember, she had a provoked DVT from an ORIF of her hip fracture, but she was treated for 6 months and it was stopped, and that was likely due just to the end of the risk. So case one, we're going to go through some more. 35-year-old female is presenting to your clinic. Her father was recently hospitalized with DVT-PE and was found to be heterozygous for factor V. She and her siblings decided to test, and she was also found to be heterozygous for factor V. She had never had VTE and uses condoms. Does she have to do anything? And the answer is no. If you are asymptomatic and have a thrombophilia, the risk of you actually having a DVT is quite low, and you don't need to be prophylaxed as an ongoing. But if you're exposed to high risk, then you're prophylaxed, right? So the word prophylaxis is used to mean different things in different clinical scenarios. Again, you don't just need to be on the drug as a routine, but as your routine medicines, but strongly prophylaxed if you're going to be exposed to a high risk situation. So here we look at so normal, we can see at the risk is, this is a normal person, and this is a risk for the first episode is quite low. And there is an increased risk for oral contraceptives, prothrombin gene mutation, factor V Leiden heterozygous. There is an increased risk, but the risk is not really much more, or it isn't really different from being on anticoagulation, the risk of bleeding. And again, many of these doctors that I talked about, that I just mentioned in that article, the vascular surgeons were asked about bleeding versus clotting, and they were all more worried about the clotting than the bleeding, but devastating bleeding can happen. So if the risk is 2 to 3% for bleeding and the risk is 2 to 3% for clotting, but nothing's ever happened, I think it's tough to decide that you're going to treat those people. I would mention that I have had a factor V Leiden positive patient who had multiple bouts of DVT because she clearly had some other undetectable thrombophilia that we just don't know about. And she recurred, and eventually she was put on lifelong. But all we know is that she has a heterozygous for factor V. So don't get stuck on that either. Here we go. 39-year-old presents to your anticoagulation clinic, history of an idiopathic DVT, and was found to have prothrombin gene mutation. She's been on warfarin for 6 months. She now is asymptomatic. What's your next management? And here in this slide, this goes stop warfarin. But again, not everybody does that. Another thing I'd mention that, anticoagulation clinics. Well, I actually now have sort of like an anticoagulation clinic. And I was a little bit called out, but appropriately so, because I wasn't really unbelievably documenting every single time these patients come. So the doctor, the primary care doctor, can ask for records. If you're going to embark on this, it is a pretty big undertaking because you have to have records, as to what you're doing, why you're doing. Every time the patient comes into the clinic, it has to be updated. You have to follow up on these patients. You can't lose them because there's a lot of responsibility. So if you're going to try to get, obviously venous insufficiency patients, but you're going to take care of all these DVTs along the way, you're really going to have a really smooth, efficient process to get them in, get them out, but get everything documented accurately. And I use the OBVs for that. DVT, OBV. DVT, OBV, that's what we do. All right, so here we go. The risk for, this is again a risk for the incidence of first episode. You can take a look at those numbers. Again, more than normal, but again, close to the risk of bleeding. And so you have to really weigh those two together. So when someone has a DVT, and they have a thrombophilia versus having an unprovoked DVT, the risk of recurrence is very similar. So having the thrombophilia didn't really do anything. So again, testing didn't really make a difference. It's unprovoked. And again, from that first article we talked about, Having an unprovoked DVT or having an unprovoked DVT and you know about the thrombophilia, it doesn't change what you're going to do. They're about the same. So testing may not be really necessary in that case. It is interesting to know, though, when we get to the next slide, that if the DVT initially was provoked, the recurrence rate is 1.8%. Versus idiopathic with a thrombophilia, it's almost double that. So I think that is sort of what people have seen in practice. And so that is why now with the mini prophylactic doses of Xarelto and Eliquis being the 10 milligrams once daily or the 2.5 milligrams twice daily, which have about a 10-fold decreased risk of significant bleeding. So you're talking about 0.3%, not 3% anymore. That may also be leading people to continue therapy for a longer period of time. Although again, then it all has to be studied. 29-year-old female patient with no past medical history presents to your clinic. She states that she has several relatives, blood clots, and wants to be tested for thrombophilia. None of her relatives have been tested. She wants to start OCPs. Would you send off a workup? For me, I know that this talks about, that it's a complex decision. I don't think that's complex at all. They say that it's only 20% predictive that a non-medical person with this thinking that people have had blood clots will actually end up in a familial thrombophilia, but 20%, if you have OCPs, you're going to see in a moment, and you combine that with a hereditary thrombophilia, you have an extremely high risk of clotting. If she has a family history of clotting, she is going to get a panel sent off. And I've done that, and you find factor V Leiden, and then you refer it out to the OB to decide with her what type of contraception she wants to use or how they're going to manage the pregnancy. Of course, we're not going to do that, but we are the DVT experts. Quite frankly, if you look at who they looked at here in this JBS article, it wasn't hematologists managing these patients, it was vascular surgeons. Okay. And this just speaks to the fact that OCP alone has a low risk. Thrombophilia alone, many of them, the heterozygous ones especially, have a low risk. But when you combine factor V Leiden and OCPs, or prothrombin gene mutation and OCPs, all of a sudden that risk goes up by 10-fold. And it is a very different, it is synergistic, it is not just additive. Okay, which of the following, if suspected, deserves further workup? PNH, antiphospholipid, malignancy, none of the above. And the answer, in this circumstance, and I guess I'm broadening it a little bit, but the answer here is PNH, antiphospholipid syndrome, and malignancy. So in terms of malignancy, the thinking is that you do not chase down every malignancy, but you make sure that patient has been screened appropriately for their age, and you refer them back to their clinician if they haven't had their colonoscopy. Most of those that turned out, so they did another study that's in JBS that looked at it, and it was 2.4% went on within 6 months to declare a colorectal malignancy, or a GI malignancy, I should say, not necessarily colorectal, but a GI malignancy. So people need to be, have had their breast screenings done, their colorectal screenings done, their prostate, all of their normal age appropriate screenings for malignancy. Speaks to that. Antiphospholipid syndrome we talked about. PNH is a very rare disease. They're going to be pale. They're going to have dark urine. It's 3,000 to 6,000 cases, I think, a year in the whole United States. So that is a very uncommon entity, but you should know about it, I guess. And here's that slide that I was talking about, showing how testing can be difficult in the setting of both heparin and warfarin, but certainly acute VTE. Again, your anticardiolipin antibodies may be elevated. Lupus anticoagulant is prolonged. That's the APTT LA. And then your protein C and S and antithrombin are decreased. Factor VIII level is increased. Again, a tough time to test, and really, what are you going to get out of it? Case 5, a 30-year-old G4P0 woman presenting to the ED with acute dyspnea. Her exam shows multiple necrotic skin lesions, positive for multiple subsegmental PE. She's hemodynamically stable. What's most appropriate step? So in this case, because of the skin lesions and the aggressive nature of this multiple skin infarcts, they're thinking that this is antiphospholipid syndrome in an aggressive form, which it can be. And so they're going to not only start anticoagulation, but they're going to start that workup knowing that they're going to have to repeat it in 12 weeks. And that's exactly what they did. So antiphospholipid syndrome, you have to have clinical and laboratory. Remember, because 10% of the screening population is just going to have these. That doesn't make the disease. And again, if you test during this acute event, if it's negative, that's great. But if it's positive, you're still going to have to repeat it. Again, laboratory criteria: lupus anticoagulant, anti-cardiolipin antibodies, glycoprotein 1 antibody positivity, and the findings redemonstrated. And again, wide variety of clinical presentations. This is clearly one of those diseases, along with malignancy, along with the PNH, where it's been clearly shown that these people will require, even after one unprovoked event, will definitely require long-term anticoagulation because the recurrence rate is just too high. So this is just already what we've said. Next case, 35-year-old with no post-medical no PMH is referred to your clinic after a family member developed DVT during pregnancy. The patient wants to be tested for thrombophilia. She's found to be a carrier. She uses condoms. So this is the simple one, right? She may be factor V Leiden, but it's irrelevant. She's factor V Leiden, but it's not going to affect her. She's using condoms. She's not using chemical contraception. So she doesn't have to do anything. In patients with a known thrombophilia, but without prior history of clotting, anticoagulation prophylaxis is not recommended, right? We went through that. But that's not the same as prophylaxis when you're being when you're going to be provoked. That's just prophylaxis on a daily basis. Here's a second DVT with antithrombin 3 deficiency. Again, this person had a second event. So this person is indefinitely. And as I said, one unprovoked is really up for debate, and most people are not conforming to stopping people, at least in the study that I just referred to, are not stopping at the standard 3 or 6 months. They're doing extended treatment. All patients with a second episode of unprovoked VTE should receive lifelong anticoagulation. 39-year-old is being seen. She's been on warfarin for 6 months. She's now asymptomatic. And again, this slide, because it's based on that one unprovoked event with a hereditary thrombophilia, the data I showed you, but again, it's not as clear as the slide is making it. Here, they're stopping warfarin. With the exception of malignancy, patients do not have higher rates of VTE recurrence after standard treatment. Okay, we've gone through it. And then here, suspected DVT, which ones certainly do require extended treatment for sure: PNH, antiphospholipid, and malignancy. We've been through this one. 21-year-old wants to start OCPs for a menstrual regularity. Mother is known to have history of heterozygous factor V. She's never been tested. How would you counsel her? And clearly her risk is dependent on whether or not she has a factor V. And that's just what we talked about. And then we're done. Any questions?
So thank you, Evan, as usual, very comprehensive. So for the fellows, this presentation is very important. And, Evan went through a lot of information, so make sure Stephanie sends out to everybody. But there are lots of board test questions on hypercoagulability states. So I think one of the most important things that Evan said is that because you have the gene, it doesn't necessarily mean you're going to clot, and your recurrence rates are the same. So for me, the inflection point on determining whether or not somebody should be considered for lifelong anticoagulation is if the clot was unprovoked and if you had at least 2 or more. So if you have somebody with a family history who has the factor V Leiden, 2 unprovoked clots, that's the person that you should consider lifelong anticoagulation for. The other parts of it, so Evan talked about protein C deficiency. So a frequent test question is about Coumadin skin necrosis. So the mechanism behind that is that the protein C and protein S are vitamin K dependent proteins. When you put somebody directly on Coumadin without bridging them with heparin, you eat up all of those vitamin K sources, and you get a functional hypercoagulable state. And that's why when I was a resident, it was drilled into my head that you can't start somebody on Coumadin right away because of the possibility of a protein C deficiency. The other part of the test question is where that Coumadin skin necrosis occurs. So this tends to be more common in women, and it tends to occur in the buttocks area. And if you've ever seen somebody with a Coumadin skin necrosis, it tends to be massive and in areas where there's large amounts of fat. So it's around the abdomen, around the belly, and it tends to be a huge wound problem because it's a transmural thickness wound. So it's a bad thing when it happens. So the other thing is, the other test question is, which are the clotting factors that are associated with arterial thromboses? And, Evan went through that. It's the phospholipids, it's the homocystinemia, and protein S. That's the big one that's on the test question all the time, is that protein S is also associated with arterial thromboses. The other thing, Evan mentioned that you can't or you shouldn't be doing these workups while someone's on anticoagulation. So the reason for that is that heparin binds to a lot of these factors, and it artificially decreases them. So you're going to get false results when they're on anticoagulation. Now that is only true of the factors that are not PCR tests. So when someone's on heparin or anticoagulation, you can still test for factor V, S, and MTHFR because that's a gene test and it's not affected by the anticoagulation status of the patients. So, and finally, for homocysteine, which we didn't really talk a lot about, there's a lot of concern about homocysteine, but it really is not that clinically relevant. When you get the test results back, make sure that you look at it carefully because there are 2 genes for homocysteine. So if one of the genes comes back normal and the other gene comes back heterozygous, that person has a normal profile. The risk only increases if both of the genes are heterozygous. So that's another thing to keep in mind. So when you see these homocysteine gene levels, don't go crazy and get blood tests for homocysteine in urine. Most of the time, it's not a useful finding unless you have somebody who's had a massive clot. Anybody else have any questions on this?
Can I make a comment?
Yeah, go ahead, Sigurd.
Dr. Harris, excellent presentation. We appreciate it. For the sake of fellows mainly, as you guys recall, we had discussed a very nice article last October. And to emphasize what Dr. Harris said, the need for workup is really not, it's not that it's necessary. And the evidence was based in over 800 patients that they had DVT and workup for the hereditary problem, and they found that there was absolutely no difference in recurrence at all, 15 versus 17%, and there is no need for workup. But they, as Dr. Harris also mentioned, the fact that something that they found in that paper is that unprovoked DVT showed definitely high recurrence, but something that was not mentioned this morning, in that paper, there was also high incidence of recurrence in those that have BMI over 40. So just as an evidence, that was a good paper that was presented by Dr. Lee a couple of months ago.
And one last thing, Dr. Harris emphasized that if you are going to do one of these workups, one of the biggest mistakes I see in trainees is that they just order a protein C and protein S level without the activity assay. So you can have normal levels of protein C and S, but remember, it's a functional deficiency. So if the protein C is not working, you can still have a normal protein C level, but still have a factor V Leiden because the genes, the protein's not working properly. So that's the number one problem I see. And it's not just in protein C, by the way. You could also order a protein S activity level as well. So if you do order these tests, don't just order the protein C and S level without the assay, because it's a useless finding if you have a low level. If you have a normal level, it can still be a functional resistance as well. So anybody else?
Thanks, Evan.
All right. Always a good talk, Evan. I'm glad you figured out the computer stuff this year. So it was good.
Ask Stephanie about it yesterday afternoon.
I know she told me. All right. Have a good weekend, everyone. Take care.